Hi everyone, this is Pete Morris-Sudi, pre-hospital care specialist with SWORB, and today I have with me Dr. Lauren Leggett, our Medical Director of Education. Hi Lauren.
Hi Pete. Hi everybody.
Today we'd like to cover the pediatric patient. The objectives for today: by the end of this presentation, you will be able to discuss the pediatric chain of survival, describe the role of the paramedic in pediatric care, describes techniques to assist with crisis resource management in pediatric pre-hospital care, while discussing components of the pediatric assessment, and reviewing and implementing the use of the Broselow Tape. So the pediatric chain of survival is needed in the pediatric population. It acknowledges that this is a scary and emotional time, as well as a medically challenging time, as pediatric patients vary in size, physiology, and always it's not a common thing for peds to be sick. And yet, with the following resources we're going to provide you with, such as the Pediatric Assessment Triangle and the Broselow Tape, you can be empowered in your assessment and treatment. So Lauren, talk to me about the pediatric chain of survival.
Sure. So you'll note that the pediatric chain of survival is different from the adult chain of survival in that the first link is prevention. So this includes basically those things that would reduce injury and death in a child. So this is a shared responsibility. Saving a child's life involves a combination of efforts by the community at large, caregivers, first responders, and healthcare professionals. As healthcare providers, we can educate and encourage parents and caregivers to adopt preventative measures to protect their children. Some initiatives include reducing the risk of SIDS, preventing motor vehicle injuries, preventing drownings, burn injuries, and choking.
So what are some of the non-traumatic causes for cardiac arrest in children?
So from the list here, you can see a couple, and remember, these are not all inclusive. So bronchospasm and drowning, congenital cardiac abnormalities or arrhythmias, foreign body aspirations and obstructions, bad gastroenteritis, seizures, sepsis, upper and lower respiratory tract infections, and SIDS or sudden infant death syndrome.
So what's the role of the paramedic? We have to remember that children are not small adults. A child's physiological response to a critical illness or injury differs from that of an adult. The signs and symptoms of distress may be subtle, and the impact of an injured or acutely ill child affects the family and the first responders more than the child. When treating a child, we must remember to treat the family as well. Keep them informed. Allow them to be part of the care or treatment plan if appropriate. Remember, physiological and emotional management of the family is important in these critical times. So, what are some of the pediatric pearls, Lauren?
Thanks, Pete. So again, not an inclusive list, but some things to remember. Never ask a parent or a caregiver to restrain a child if they are uncomfortable with doing so. It could create unintentional harm between the relationship of the parent and the child. Praise cooperation with procedures with the child, and remember that privacy is important for these children. Explain things clearly and allow time for questions when appropriate. Involve the patient in treatment wherever possible, and always consider other possibilities for their presentation. Is there signs of abuse, substance abuse, or toxicity for either the parent or caregivers? And is there any signs of self-harm or harm to others?
So the crisis resource management piece, there's a lot to take into consideration with the assessment and treatment of a pediatric patient. Size and physiological differences, emotional impact. So in order to simplify and empower you, we will be introducing some resources, such as the Pediatric Assessment Triangle, and the length-based tape, i.e. the Broselow. Remember that the impact of an injured or critically ill child is devastating, not only for the child, but also for the child's family, and especially for the first responders. Please remember to talk about it. So patient assessment.
So your initial evaluation or scene survey is not that much different from the adult population. So remember to look for hazards. So any hazards that are present and visible or can tell you about mechanism of injury or illness for the patient's presentation. Look for pills, medicine bottles, household chemicals that may indicate toxic ingestion. And does the injury or history of events coincide with the mechanism of injury? Always observe the interactions between the caregiver and the child. Other important things to look for include cleanliness, orderliness, and safety of the home, the general appearance of the child or other children in the home, presence of medical devices, and indication of any obvious signs of parental substance abuse. And always remember to determine if additional resources are required, such as the police, CAS, supervisors, etc.
So pediatric assessment components. So here are the steps used to perform a pediatric assessment, which is described as linear. The first is the initial assessment. This is where you'll apply your pediatric assessment triangle, or the PAT. Right? Now remember, this is your first impression. All right. Secondly, then you'll proceed into the primary survey and then into the secondary survey. So Lauren, can you help me out with the pediatric assessment triangle?
Sure, Pete. Let's look at that next. So again, remember, this is your first impression. So in order to help you with your first impression, the pediatric assessment triangle is made up of 3 separate components. So the first in blue is appearance, the second in green is work of breathing, and the third in red is circulation to skin. We'll be going through these components next.
So the PAT. Remember, the PAT is applied before approaching the child. Pause a short distance from the patient and use your senses. Look, listen, and smell to quickly determine if a life-threatening problem exists. This is usually complete in less than 60 seconds, and this helps you determine if the patient is sick or not sick. Remember, be diligent and frequently reassess the pediatric patient, as they can go from not sick to sick rapidly. So Lauren, can you help me out with the appearance on the PAT?
Sure, thanks Pete. So the first component of the PAT is the blue triangle of appearance. So this reflects the adequacy of oxygenation, ventilation, brain perfusion, homeostasis, and central nervous system function. In order to help you with this assessment, you can use the acronym, TICKLES. So T for tone, does the child have good muscle tone or are they completely limp like a noodle? I is for interactiveness, how alert is the child? Are they reactive to what's going on around them? C is for consolability, can the child be consoled by the parent or caregiver? L is for look or gaze, does the child track objects appropriately or do they have a blank, wide-eyed stare? And finally, S is for speech or cry. Does the child have a strong or weak cry? If they're at the appropriate development age and they're able to speak, is their speech garbled or confused?
And now the work of breathing.
All right, Pete, I'll take us through this one as well. So the second aspect of the triangle, the green work of breathing, reflects the adequacy of airway, oxygenation, and ventilations. So the assessment areas include body position, visible movement of the chest and abdomen, the respiratory rate and effort, and audible airway sounds. So normal findings of work of breathing would be quiet, non-labored respirations with equal chest rise and fall, and the respiratory rate would fall within normal limits for their age. Abnormal findings of work of breathing include the child being in the sniffing or tripod position, head bobbing, nasal flaring, and sounds like stridor, grunting, gasping, gurgling, wheezing, and finally, if you note obvious accessory muscle use.
And now circulation.
Okay, I'll take us through this one as well. So the third component of the triangle, circulation to skin, reflects the adequacy of cardiac output and perfusion of vital organs. So you're using your assessment of skin color and skin temperature to help you with this one. So normal findings include color and temperature within normal parameters. Abnormal findings are more striking and include pallor, mottling, cyanosis, and the child being either hyper or hypothermic.
So sick versus not sick. So remember, this is all based on your first impression. Decide whether the child is sick or not sick. If the child's condition is urgent, see task 1 or 2, proceed immediately with rapid assessment of the ABCs. Treat as you find and perform necessary interventions. If the child's condition is not urgent, proceed through the primary survey, followed by the secondary survey with vital signs, focused history, and physical exam. And then remember to have ongoing assessment, because a child can go from not sick to sick in a heartbeat. So what are some of the pearls, Lauren, of the PAT?
Thanks, Pete. So again, the PAT is applied within the first 60 seconds or less. So we can use those 3 different sides of the triangle to help us determine what's going on with this child. So starting on the left-hand side, the top triangle there, if the appearance, circulation, and work of breathing are normal, the patient is stable. If you note that their appearance and circulation is normal, but their work of breathing is increased, this child is in respiratory distress. And again, this can be noted within the first 60 seconds. Finally, if the child has an abnormal appearance, along with an abnormal work of breathing, plus or minus abnormal circulation to skin, this child is in respiratory failure. If the child has an abnormal appearance and circulation, however normal work of breathing, this is a sign of shock. If the child has a normal work of breathing and normal circulation, but components of their appearance are abnormal, this is a clue to a CNS or metabolic problem. Finally, if the appearance, work of breathing, and circulation to skin are all abnormal, this is signs of cardiopulmonary failure. This child is sick.
Awesome. The patient treatment now. Moving on to the patient treatment. On this slide, we are now providing pediatric vitals. Now remember, these are a reference, right? They're all age-based. So we have respiration rate, heart rate, skin condition, blood pressures, normal tensive blood pressures, and how to calculate, and hypotensive blood pressures, and how to calculate. What would make this easier in this assessment would be referring to our Broselow tape. So our Broselow tape, or pediatric emergency tape, is a color-coded tape which is used in pediatric emergencies. It's related to the child's height, as measured by the tape, to his weight or her weight, providing medical instructions and medication dosages. Please remember that ALS-PCS doses are preferred in these cases. It uses the estimated 50th percentile, so if the patient looks heavier or lighter, consider a zone higher or lower for medication dosing if applicable. Always use the tape measured length zone for equipment selection, regardless of body size. Now remember, this is used for patients less than 12 years or a max weight of 36 kilos or 80 pounds. This tape is used in the hospitals, right, Lauren?
Oh yes, in fact we have crash cards labeled with the drawers for each of these zones, just to help decrease some of that cognitive load. So basically crisis resource management, and why we wanted to talk about it today.
And if we pick a color, then we can notify the hospital ahead of time as well that we're using that yellow or red or purple color. And that way they can set up as well.
Exactly.
So how do you use the Broselow tape? Well, first thing, lay the patient down. Use one hand to hold the red end to the head. Remember, red to the head. Then run the tape down the length of the body until it's even with the heels. The tape will reveal an approximate weight in kilograms and their color zone. Treat according to their color zone. Here's some of the references provided and used during this presentation. Thank you for joining us today. If you have any questions, please feel free to contact any one of us, myself, Dr. Leggett, or any of the pre-hospital care providers, and we'll be happy to assist you anytime. Thanks for joining me today, Lauren.
Thanks, Pete. This was fun.
Excellent. Have a great day, folks.
Bye, everybody.